welcome everyone. Let's go ahead and get started. My name is Ricardo Valadez. I'm with Americans for Financial Reform. I'm a private equity campaign manager, and we're here today to present a recent report by AFR called Doctored by Wall Street: Policy Solutions for Private Equity in Healthcare. Welcome to you all. We look forward to hearing from our esteemed panelists who will cover the contents of the report. We have a very straightforward agenda today. After some introductions, the panelists will cover the contents of our report, and we'll leave plenty of time for question and answer. The Zoom webinar format does have a question and answer option, a button. So if you have a question, you can drop it into that Q&A at any time during the presentation, and we will look over the questions and get to them at the end. So please feel free to use that function. So a little bit about Americans for Financial Reform. We are a nonpartisan and nonprofit coalition of over 200 civil rights, consumer, labor, business, investor, faith-based, and civic and community groups. We were formed in the wake of the 2008 financial crisis, and we are working to lay the foundation for a strong, stable, and ethical financial system that serves the nation as a whole. Our panelists today, I will introduce our panelists and then hand it over. The author of our report is Robert Seifert. He's a senior fellow with Americans for Financial Reform. He's a public policy professional with over 30 years of experience in the public sector, not-for-profit, and university settings. His primary focus is on healthcare policies and programs that seek to improve access to care and correct inequalities in healthcare delivery and outcomes. We will also be joined by Erin Fusay Brown, who is the Catherine C. Henson Professor of Law and the Director of the Center for Law, Health, and Society at Georgia State University College of Law. She specializes in healthcare law and policy, and her research focuses on healthcare markets, consolidation, and cost control. So without further ado, I will pass it to our panelists. Bob.
Thanks, Ricardo. Good afternoon, everybody. It's great to have you here. I'm happy to speak about our report. Let me start off, first of all, with just a very basic premise on which everything else builds, and that is that private equity, the private equity model is incompatible with healthcare, with the healthcare system. This point has been made in many, many academic articles, journalistic exposés, personal experiences. We've seen in the literature increased mortality, reduced quality in private equity-owned nursing homes, increasing prices due to market consolidation, the bankruptcies of sold community hospitals, leaving communities without health care, and so forth. Many other examples. The reasons private equity, I'm going to call it PE, just to keep things short here and punchy. The reasons PE and healthcare are incompatible, I think, are pretty straightforward. PE has a singular focus on maximizing profits. That's the business model. So they employ cost-cutting strategies, for example, by shrinking their staff, and revenue growth strategies through acquisitions and consolidation and things of that nature. In pursuit of in pursuit of profits, compromises access, quality, and safety. Secondly, debt financing and real estate transactions impose a financial burden and divert resources from patient care from facilities that are taken over by private equity investment. And then the business model also usually employs a short-term ownership cycle. So 5 to 7 years, they're going to buy a business, try to accumulate other businesses around it, and then sell it off at they hope, a large profit. This is not conducive to a healthcare model where improvements take a long time and commitments to the community are very important and require kind of long-term relationships. And the health impacts are in fact dire. Just to single out a few pieces of evidence, we've seen residents of private equity-owned nursing homes have higher mortality rates. and given more antipsychotic medications. We've seen PE-owned physician practices with higher costs and using lesser trained staff with minimal or no supervision. We've seen something that's been called stealth consolidation, which Aaron is going to talk a bit about, I think, from small serial acquisitions of, for example, in the dialysis industry, dialysis companies that were able to evade federal antitrust scrutiny, which degraded quality to the point that estimates are that costs thousands of lives through dialysis care. I also just want to make the point that we need to remember that the profit motive is really everywhere in healthcare, even among players that are nominally nonprofit. Private equity is really just an example, an extreme manifestation of this profit-seeking behavior. But it's a special case, I would say, that warrants special attention for the reasons that I just talked about. And I would add to that list the kind of shadowy way that PE tends to operate, which we'll talk about a little bit more, which allows investors to evade accountability for the outcomes of their investments. Can I have the next slide, please? So our report focuses specifically on federal policy levers that can be used to reduce PE's influence on healthcare. And the report identifies 3 areas where policymaking or simply more assertive action using existing policies and laws can make a difference. And these 3 areas are, first of all, stepping up the enforcement of laws we already have against false claims, self-dealing, and antitrust. Secondly, changing the incentives and closing payment loopholes in the Medicare program. And third, improving the transparency of ownership of healthcare companies. So those are the 3 kind of high-level areas. We're going to go into a little bit of detail on it now, and then we'll have some time for questions and discussion at the end. So to elaborate on the first recommendation, I'd like to turn this over to Erin Fusé-Brown. You've heard her introduction. I'd just like to add to what Ricardo said. Erin's scholarship on this topic is quite extensive and very compelling. It was a major source for me for the report that I've done here for AFR, as I think it is for many others concerned about this issue. I'm grateful for that. I think we're all grateful for that and for her joining us today. Erin, let me turn it over to you.
Thanks, Bob, and thanks to AFR and Ricardo for inviting me to participate. I read the report. I, talked to Bob about it when he was writing it, and I think it's a real, terrific bringing together of a lot of the issues, but also importantly, some of the policy levers that are available to address this very pressing problem, and one that is getting a lot of attention, both on the Hill, but also just, among dining room conversations. You're starting to hear it enter the sort of common understanding that there's this thing called private equity that is now really swept healthcare, for everything from hospitals and nursing homes to physician practices, and I think it's starting to become part of the public conversation. So this is great to be here. So I'm going to pick up on a little bit of the what we can do given existing laws. The first sort of bucket of laws, I would say, that we have at our in our toolkit, for lack of a better word, are the fraud and abuse laws. And the federal fraud and abuse laws I'm talking about are the healthcare laws, the Stark Law and the anti-kickback statute that are specific to federal healthcare programs, but also the False Claims Act, which is often used in tandem with those other 2 fraud and abuse laws to get at things like improper coding, upcoding, overbilling, et cetera. So these fraud and abuse laws, have been designed for many years to really get at improper financial motives that might be in place that sort of corrupt the patient care process, the physician decision making or the referral patterns, because financial incentives get in the way of what's best for patient care. And so that's sort of the overarching goal. And as a result of these concerns, because there's so much money that flows through the federal healthcare programs, there is an effort to counteract the natural tendency for there to be, efforts to overbill or upcode or shade the amount of reimbursement to create more revenue. Of course, private equity, as Bob pointed out, is very adept at creating revenue opportunities through identifying sort of payment loopholes or through identifying ways to rapidly upcode. Again, not creating more value, not necessarily providing better patient care, but finding a way to monetize the quirks of the billing and coding system that we have. And so the fraud and abuse laws can really get at that because they are very complex. They're very hard to comply with. And in many cases, they come with something called treble damages, when that was basically triple damages for False Claims Act violations. And so that threat, it's sort of a per claim penalty plus, you multiply those penalties times 3 and you add it all up. And for typical healthcare institutions, that's like bet the company ruinous liability that they work very hard to avoid. Private equity moves quickly. It brings a whole different sort of approach. And so you can bet that there are going to be times when the sort of press for revenue maximization is going to run afoul of some of the rules of the complex rules of Medicare billing, whether it's proper supervision, whether it's, using the right billing code for the type of service that's being provided, whether it's, exaggerating the acuity of a patient's diagnosis, or whether it is, or structuring your professional practice that they're rolling up into these large, sprawling, practices, whether or not those can actually, qualify for the complicated rules, Stark Law rules for in-office ancillary services to capture those referrals for things like imaging, for things like rehab services, or other things that might be the source of revenue, and that they're trying to kind of, again, encourage and capture those referrals for revenue purposes. All of those things can be, policed through fraud and abuse laws. And so I think that the main policy recommendation here is to sort of look at who are the potential enforcers. Well, the potential enforcers include the Department of Justice, right? The Department of Justice does a lot of fraud and abuse enforcement, particularly in the healthcare space. Also the federal agencies, HHS, OIG enforces the anti-kickback statute, the CMS enforces the Stark Law. And then what we have are the private whistleblowers. So there are just like, the idea was the government can't possibly police every instance of fraud that's out there. So that these laws have, particularly the False Claims Act, have what are called qui tam relators, who are private whistleblowers. If someone, who's in the company and has personal knowledge of some of these nefarious billing or revenue strategies or patient care strategies that might run afoul of the laws, then they can blow the whistle and be a part and bring that case sort of on behalf of the government. Of course, the government can join the case, take over investigation, and there's, so one of the strategies here is to encourage not just the federal enforcement agencies that are already probably paying quite a bit of attention to this, but also to encourage private whistleblowers to look carefully at this for the reason being, it is something that we think is a ripe area for enforcement. There are a few cases that are already out there that set the precedent for going after the private equity fund itself, not just the physicians and the healthcare act facilities sort of at the bottom of the food chain, but really because of the active management of private equity companies. They come in and that's their whole revenue strategy. They take a controlling interest in their portfolio companies. They direct them toward their revenue strategies, and they are very active in encouraging or at least pressuring those revenue targets to be met. And as a result, they have deep knowledge and involvement with these revenue strategies. So this sort of idea of being able to pin the liability all the way up to the management company, the private equity fund. In the case of private equity, I think there's actually quite a bit of there's some precedent for being able to do that. So the policy strategy here is encourage more of this enforcement, particularly by whistleblowers. Figure out a way to kind of identify and bring these cases, and also to encourage the government to go after the maximum damages when they do have a private equity defendant. There's sometimes a concern with the treble damages can get to be so much that healthcare companies can collapse under their weight and shut their doors. I think there's less of a concern of that with the deep pockets that is the private equity fund. They see this as the cost of doing business, and so it is that's the other policy lever there, is to really encourage the government, if they are settling with or investigating a private equity owned company, to seek the maximum damages. So I'm going to turn now to the antitrust laws. As Bob mentioned, another risk that we see of private equity investment in the healthcare space is it takes a fragmented market, say, hospice or physician practices, and it uses consolidation through this sort of investment and roll-up strategy to really consolidate the market, grow their market share, which of course comes with the ability to raise prices, particularly in the commercial market. So antitrust, of course, is our biggest tool for going after anti-competitive mergers or market power acquisition and abuse. And so one of the key policy recommendations here is to really push. I think here we might need a little bit of reform from the federal government, but to push for ways for these small acquisitions not to fly under the radar. So right now, the minimum threshold to report a transaction to the federal government, the antitrust agencies, is $111.4 million per transaction. So, a physician practice or even a hospice acquisition is not going to trigger reporting. So we just recently heard from the FTC that there is a proposed rule to modify the Hart-Scott-Rodino reporting pre-merger notification form. And that would not necessarily change that threshold, but it does sort of cause the pre-merger notification to provide a bit more information about both the organizational structure, the investors, including the limited partners, the private equity owners, any kind of common controlled entities, to bring all that information and disclose it as part of their pre-merger notification, and also to calculate, looking back 10 years, what is the total value of transactions in the same sort of business service area or this line of business. So again, it doesn't necessarily allow them to aggregate all of those prior transactions to cross the threshold, but if they are already above the threshold, we're going to have a lot more visibility if the rule gets finalized into the nature of these transactions, particularly. So it does deal in some ways with the opacity and gives the antitrust enforcers more tools to go after these, to study, and then also to go after these transactions. There are a couple of other things that we could use, of course, and that would be it would maybe take statutory change, which is to allow for sort of the consolidation of all those serial transactions in order to trigger reporting. The other thing that we are already seeing the FTC and DOJ doing is when they are negotiating a settlement or a consent decree with a merging party that it's opposing the merger. One of the things we're seeing is that there's sort of a prohibition on further transactions or a prior notification requirement, so that they can't just go up and start to gobble up, these tiny little practices or tiny little entities and start to grow their market power that way without notifying the FTC first. And then there's also forced divestitures and other things that can be a bit more structural. And then finally, the HHS authority under the antitrust laws is, I think that's something that talk about in the report, as well as the Medicare and Medicaid exclusions list. I'm just going to mention them really quickly. Just to say, for the sake of time, I'm not going to get into this, but I think one of the things that we want to do, that the theme here is to use the tools we have, but also to make sure that they're being enforced, because I think a lot of the federal agencies say, they have limited resources. So that's why fraud and abuse, publicize and study the Medicare and Medicaid exclusions list of prior violators. If they're involved in new transactions, that should be something that advocates can study and expose. Fraud and abuse laws, whistleblowers can bring those, as well as the federal government. And then antitrust laws, again, allowing for some more of these, some more sunlight into the transactions that are being reported, and then push for change to allow more of these transactions to actually be reported to the federal antitrust enforcement agencies. So I think I'll leave it at that. There's more I can answer in Q&A, but I want to turn it back over to Bob.
Thank you, Erin. That was great. Great information. Yeah, and we will get back to a lot of this, I'm sure, in the Q&A. Let me just fairly quickly go through the substance of our other two recommendations. Excuse me. Our next area of recommendation for policy action is around how Medicare pays for care. There are several recommendations in the report concerning both the so-called traditional Medicare and Medicare Advantage, which is the part of Medicare where beneficiaries can get their coverage through commercial managed care plans. There's a lot of gaming of the payment rates that profit-seeking health plans can pursue and do pursue on the Medicare Advantage side. And there are policy levers available to CMS to make that less attractive. I encourage you to take a look at the report, or we can talk more about it in the Q&A on this, on the gaming of the rates in what's been called the Medicare money machine. But right now I want to spend a few minutes talking about another recommendation, because there will be a concrete opportunity coming soon to influence policy in this area. That's the area that's circled on the slide here. The area of minimum staffing requirements. In a system where a provider is paid by a case rate or a per diem rate for services, there is a motivation, of course, to reduce costs, thereby increasing profits, by stinting on staffing. In healthcare facilities and practices, labor is where most of the operation costs are. So a profit-making strategy is to reduce the staff or to shift responsibilities to lesser trained staff, often with little or no supervision. This is something that Erin touched on a little bit earlier. There is particular concern about this practice in nursing homes, where not coincidentally, private equity ownership is associated with a decline in quality of care and an increase in mortality. One estimate was that about 20,000 additional deaths occurred in nursing homes over the past 12 years or so because of private equity ownership. So we're expecting a draft regulation soon from CMS that establishes minimum staffing levels for nursing facilities. We expect the focus to be on improving safety in nursing homes, but it will also be getting at a key private equity cost-cutting move. AFR plans to review and comment on the private equity angle of the proposed reg, and we know that many of our friends will also be looking at the broader healthcare implications of this. We encourage all of you to do the same and to stay tuned to news from AFR about this reg when it appears, which, as I say, I think will be in the next month to 2 months, I believe, is our latest intelligence on that. Okay, and then there's more on traditional equity as well. I'd like to move along, though, to the next slide and to our third recommendation, which is about transparency in general, and transparency of the ownership of healthcare facilities. Transparency is important as it makes private equity owners accountable. It shines a light on the stealth consolidation that results from the quiet accretive accumulation that Erin was talking about of related businesses, and it enables regulators and consumers to look at overlapping and interlocking ownership, relationships with management and staffing companies, and other kind of opaque structural features that promote profits at the expense of patients. Quick look at the next slide, please. CMS proposed a rule earlier this year requiring disclosure of nursing facility ownership and requiring the owning and managing entities to disclose whether they are in fact a PE company or a real estate investment trust. That is a regulation that is still pending. The comment period closed a couple of months ago, and we're waiting for issuance of the final rule on that one. Next slide. There is more to do in this area as well. Further actions to promote transparency. While nursing home transparency is a good start, there's no reason not to try to require the same disclosure of ownership for other types of healthcare providers. Reporting requirements could be made more extensive to identify where entities have common owners, and websites that people use to help them choose providers should include this information as well. That's the CMS Care Compare website, for example, where nursing homes are compared. Finally, a national private equity ownership database would do a great deal to bring PE out of the shadows and to be more accountable for the decisions they make and influence. So though that in a very quick nutshell is the substance of the recommendations that AFR is making in the report that came out last week. We hope that you will all take a look at it. There's a companion piece that kind of lays out the issues, the underlying issues of private equity in healthcare, that gives a background of why this is a problem. But at this point, let me stop and turn it back to Ricardo to facilitate a conversation.
Thank you both so much for your presentations, and I'm going to stop the screen share here, and we will now take questions from participants. As those come in, I will start by asking, why are these the recommendations? Wouldn't it be better to just ban private equity from ownership of healthcare? Why are these particular recommendations, and also related, like why now?
Right. Well, I'll start. I love Aaron's input on this as well, but well, I think I made reference to this right at the outset that we can't just ban private equity from owning healthcare institutions. At least I don't. Well, I'm not a lawyer, so we can ask the law professor. But as I said, there's private ownership of healthcare. That's really what our healthcare system is in a lot of ways, and this is just kind of an extreme example of it. So the strategy here, I think, is to minimize the incentives that private equity, that very smart, very nimble investors seek out and try to take advantage of to turn a profit. If you make it less attractive in that sense, you can, I think that the theory goes, you can try to minimize the influence of private equity in healthcare. So these recommendations are toward that end. They're tools that are available now. They're handles that advocates and others can grab onto right now and try to work to try to change those incentives a little bit. Some of them are tougher than others, as Aaron mentioned. Some of them would require statutory change, which is a heavy lift these days. But others are not. Others are enforcement or regulatory or sub-regulatory kinds of things that can be done. And if there are enough voices calling for it, I think there are things here that can be achieved. Aaron, any thoughts on this?
Yeah, I think I agree that it would be very difficult to just sort of eradicate private equity and uproot it from the healthcare industry when it's already here. It moves very fast, and it's already here. And there are also some benefits that access to capital that the healthcare industry is saying, well, we kind of need this access to capital. And I think, so in other writings that I've done, I've taken a similar approach to say, look, private equity it's got some unique features, but it's really just a part of the for-profit healthcare system that we have. Public companies, retailers, Amazon, CVS, like there are lots of other players in the space that they're using similar techniques, and it's just that private equity is more aggressive. They're sort of they move quicker, and so it's a lot more shocking in some ways when they enter a market. And I think that the goal here is to use private equity almost, and I've written about this in another paper, as a divining rod to find those payment loopholes, to find those exploitable those sort of either market failures or market dysfunctions that private equity has found as a way to make really quick revenue that isn't providing any value to patients, and close those loopholes. So use it as, where are they going? What's the revenue strategy? What's the payment loophole that's being exploited, or the revenue strategy that is being rolled out? And then use that as a way to figure out, well, how do we minimize that dysfunction? How do we close that loophole? How do we fix the problem so that others don't follow on their tail and make the same type of revenue play?
Thank you. Just a reminder to folks, please put your questions, use the Q&A function on the Zoom webinar to pose questions to the panelists. Next question I'd like to ask is, how would you prioritize these recommendations? Which ones have the most potential to be implemented, and which ones would be most effective in the sense of, you know, the biggest bang for the buck, as it were?
Well, I was very compelled by Aaron's presentation, so I think that I think a lot of the enforcement recommendations could go a long way, especially since there are things that are already being done that just need to maybe be amped up a little bit in terms of, you know, seeking higher damages, for example, or just pursuing cases a little bit more aggressively. I would put that at the top of the list, and I'm wondering if you would agree, Aaron. But I also think that there are a lot of recommendations out there right now that have been made for years. There's an organization called what's the organization called that makes recommendations to CMS? It just flew out of MedPAC. Thank you. For CMS reforms that can be done at a regulatory level, and one of them that we talk about in the report is changing there's an adjustment that's made on Medicare Advantage rates to align them better with the payments that are made on the traditional Medicare side. That's one of the things that Aaron was talking about, one of these loopholes that private equity has figured out how to game and make a lot of money from, or just private health plans in general, actually, in that case, not just private equity. So those are regulatory things. There's, there are a lot of politics involved in that I'm sure a lot of you on this in this webinar know much more about than I do. But I would say that those are two of the top, that I would prioritize them in that way, I think.
And I would agree, and I was sort of, maybe this is too glib, but I think it's sort of, there's no silver bullet, right? And so I think to kind of understand that you need like a quiver of arrows, that there isn't going to be the one thing that solves the problem, is worth knowing when you start this process, but also to figure out, where do you have momentum? Where do you have pressure? Where do you have an opportunity? And that's where you move. And the nice thing about all of these policy options is, depending on where you sit, there's something kind of for everyone, right? Like some things take an act of Congress. So if you work for a member of Congress, then that's maybe where you focus your activity. If you there are regulatory and sub-regulatory things that the agencies can do under its existing statutory authority. There are things that private citizens can do as whistleblowers, or as people who are just participating in the healthcare system, and see these things going on in their communities. And so that's also worth noting. And it's not the focus of this webinar, but there are even levers at the state level. So a lot of the enforcement actions can be taken both by of course, the federal enforcers, but also state enforcers, like the state attorneys general, can bring some antitrust actions as well. So there's sort of like, there's something for everyone. It just depends on where do you have a lane of opportunity. And I think that's knowing what your options are, when you get the opportunity is created, or when you create that opportunity. I think that's kind of the way to think about it.
We have a question of if the panelists have any thoughts on directing public attention to these issues, to make these issues a salient political issue, and to potentially speed up the possibility for regulation and to use these tools.
I'd ask you that question, Ricardo.
Sure. Yeah, I can take that one. I mean, so that's precisely what we're trying to do with these recommendations at AFR. Where we have a coalition of folks who fight private equity in different areas, whether it be housing or retail sector, and we're mobilizing those folks on this fight on private equity. Simultaneously, we've been reaching out to folks who are already working in different areas of patient advocacy and healthcare reform, and our aim is to pull together a coalition of folks to prioritize together, and work together to build that momentum, to make it more visible publicly, to let policymakers know that there's a unified opinion on this and a push for this, and a lot of people more and more people are and working to try to build momentum for change. We have another question. What are the strategies at the state level and in which states? Some states are more bold than others and have legal infrastructure to do so. This is mostly a conversation about federal policy levers, but it's definitely worthwhile to consider what action might be taken at the state level. So either Aaron or Bob can take that.
Be my guest, Aaron. Yeah.
Okay, I'll take the first go, and if Bob, you want to add on to it. I think there are two primary, there are a couple of things states can do. The first thing is on the antitrust front. Some states have already put in place sort of oversight of healthcare transactions that gets underneath that Hart-Scott-Rodino reporting threshold that's holding back the federal agency's ability to sort of see these transactions. So in particular, states like Oregon, for example, have a pre-transaction review with much lower thresholds. Connecticut, Massachusetts, California, particularly with an aim to see to monitor these transactions, whether it's private equity or other types of purchasers. But the whole point is to be able to see these transactions, to watch them serially, and also monitor them and approve them potentially before, or disapprove them before they happen. So I think that that's one way that states are out front in front of the federal government. Not all states, but some states have really taken that on, is sort of that transaction review before the merger. And then the other area that I think states have that actually the federal government does not have this authority is what's the old corporate practice of medicine doctrine, which comes from medical licensure laws that basically prohibit the unlicensed practice of medicine, which was used in times past to get at for-profit lay entities like corporations buying up physician practices and telling them how to practice medicine. That was sort of a concern back, in the olden days, and now we still have these laws on the books. And I think there are some states that are actually starting to look at dusting off those laws, which still exist, and strengthening them to really get at this problem, which is true corporate practice of medicine, where private equity companies are not only buying up the doctors' practices, but telling them how to practice, and then locking them in with a series of financial, incentives or stock restrictions or non-competes or gag clauses or all those things to basically lock the physician in, and really take away the autonomy of the physician to call the shots, not just on the clinical decisions, but on staffing, on things like how many patients they see, and how they're going to run the practice moving forward. And once the physicians lose that control, they never really get it back. So that's another area I think that state legislatures in particular could really take this the next level, would be to strengthen the corporate practice of medicine doctrine.
Great. We have a participant who would like to dig in a little more on the specific difference between what CMS and Congress can do to reform the payment models.
Okay. Well, so as I mentioned, CMS has a lot of regulatory authority, particularly around how the rates for the Medicare Advantage program are set. I mentioned this thing called the coding intensity adjustment, which is a way. First of all, let me back up a second. Medicare Advantage, the way that it was developed, and it's been reformed a little bit over the past couple of decades, but it is basically a gold mine for health plans. It's a way to make a lot of just the way it's set up is, and it's too technical to go into now, but basically health plans are paid on a per capita basis that is in the aggregate much more than CMS, that Medicare would be paying on a fee-for-service basis for somebody who is in the traditional Medicare program for the same set of services. So in response to that, Congress created this thing called the coding intensity adjustment and set a floor of what that adjustment should be. So right now, the Medicare Advantage rates are adjusted by, I think it's 5.9%. But they have room to go higher. They have regulatory authority to make that adjustment higher, which is to say to close the gap to make it much closer between Medicare Advantage and traditional Medicare, closing one of those loopholes, right? Closing one of the attractions of for-profit companies to get into this game. For whatever reason, CMS has not taken advantage of that regulatory authority yet, but it is there. And it doesn't require any more legislation. Another area of regulatory authority is staffing, minimum staffing requirements, which CMS can set in the interest of safety, really, but assuring safety and quality of care in healthcare facilities, and that's going to be the subject of this rule that's coming out soon. So no legislation required there. And then there are a couple of other technical things around pricing, again, that CMS can sort of tweak some of the dials on how it sets prices, particularly for Medicare Advantage, that don't require acts of Congress. On the flip side, there are these things, these other Medicare kind of payment loopholes. And Erin, maybe you want to talk about this ophthalmology drug, where again, it's something that profit seekers can find and get in and take advantage of, and changing those things would require some legislation. So the way that requiring, for example, specialists to switch over from a fee for service, where the more they do, the more they get paid, to more of what's called a value-based payment arrangement, where they're getting paid for the outcomes that they deliver on a set kind of fee rather than fee for service, which would, again, inhibit the motivation for private equity to get into some of these physician specialties that they've been moving into with great alacrity lately. And then there are these things that different sites of care that pay different amounts for the same service. So if you have care in an inpatient setting versus an outpatient setting, you get paid more for the inpatient setting. Those kinds of things to make a site neutral sort of payment system requires legislation. So there's no rule of thumb, I'm afraid. I mean, some things are in statute and some things are in regulations, and it kind of varies case by case. But Erin, could you just quickly talk about this macular degeneration drug?
Yes. When we're trying to, again, using private equity as a divining rod, we're like, why are they investing in ophthalmology? What's the land grab, motivation there? And it's entirely this Part B, a physician-administered drug payment methodology that Medicare Part B has in its statute that pays physicians that administer the drug in the office. So it's usually an infusion or an injection or something that can't just be taken at home. Those physicians are reimbursed at a rate of 6% of the list price, or the cost of the drug, not the sort of a flat rate. So when there are two different drugs or multiple drugs that have different, that have the same, effectiveness, same safety profile, Lucentis versus Avastin, but one costs 40 times more, then that means the physician's practice stands to make 40 times more money by prescribing or administering the more expensive drug. And so one of the things that private equity companies have been doing is buying up ophthalmology practices and making them switch en masse overnight to the more expensive drug, and then basically pocketing that difference. Some have called this arbitrage, or it could just be called, revenue maximization. So one way to change that incentive would be to close or change the way Medicare Part B reimburses physicians for physician administered drugs. Of course, that would take an act of Congress. And so that, there's some education that needs to go on there. I think the nature of this conversation starts to feel very much in the weeds, right? Like every little policy loophole that is driving private equity in one direction or another needs to be closed individually. And then I think that that's exactly right, that some of them are at the regulatory level, some of them are at the statutory level, and some of them I think could be done even more easily than that. So it's worth kind of doing that digging if that is something that everyone's interested in.
We'll take one more question, which is, are federal agencies and members of Congress taking notice? And if so, in what ways?
Well, I think Aaron mentioned one, at least one, the FTC proposed rule. And then I had talked about the CMS rules on transparency, ownership transparency, and the forthcoming one on staffing. There are a couple of bills in Congress right now that have to do with, again, putting ownership transparency into statute rather than just into regulation, and going more broadly than just nursing facilities. They're in the House. They've been introduced to Congresswoman Jayapal has a bill called the Healthcare Ownership Transparency Act. Congresswoman Schakowsky has a bill as well that is focused on transparency of ownership, and it singles out private equity as a kind of a target for that. There's of course the Stop Wall Street Looting Act, which I think is kind of more general than what we've been talking about here, and Ricardo can speak with a little more authority to that. But yeah, so I think yes, there is some interest, there is some attention. I think the FTC in general, I think, is very interested in this area. Consumer Financial Protection Bureau as well. So there are ears, I think, at the federal level and potential allies. So it's not, you're not hollering into an empty cave, I think, on this. Aaron?
Yeah, and I think that one thing that that could probably be done more is to connect all of these dysfunctions together under one story, and that I think is what this conversation that we're having today is doing a good job of doing, which is to say this is all these are all individual symptoms of a larger problem with financialization in healthcare, and I would just point to the biggest example of Congress being able to act. It's, we shouldn't just throw up our hands and say, well, that would take an act of Congress, and so it can't happen, and that is the No Surprises Act, right? So that was driven by the problem of surprise medical bills, which was, what was that result of? It was a result of private equity-backed physician staffing firms, taking advantage of the ability to go out of network and balance bill and use surprise medical billing as a revenue strategy. And it became such a problem and such a public outcry that there was bipartisan support. It took a while, right? It was a big fight. It's still a fight in terms of implementation. But the No Surprises Act did pass. And, we just heard this past spring that Envision, one of the biggest private equity-backed emergency staffing companies, declared bankruptcy. I think there's a direct line between the No Surprises Act taking away their revenue strategy and their current financial picture. And so I think that to say that there are no good examples in recent memory of Congress coming together and doing something significant in this space is just, that's all you have to do is point to the No Surprises Act and say that can be done, but we need that sort of storytelling, and we need that sort of narrative, which I think is what this organization is doing such a good job of doing.
That's a great point.
That sounds like a great place to leave us and wrap us with. I just drop the link to the report in the chat. And we will be sending out a recording of this presentation. Please share it widely. And as I mentioned before, we are using the launch of this report to to pull together a coalition of folks who to continue this conversation, to really take action to build momentum to pass some of these recommendations. And we look forward to continuing the conversation. And thank you to the panelists, Bob and Aaron, for taking the time. And thank you for all of the participants as well. And we will see you all soon.
Thank you.
Thanks very much.
Bye.